Welcome to Inside Dentistry's one-on-one with Dr. Mike DiTolla. That's me. Tonight, we are joined by Dr. Brittany Bergeron, who will discuss minimally invasive bioactive dentistry in everyday practice. Tonight's program is supported commercially by Pulp Dent. Dr. Bergeron owns a general dentistry practice outside of Baltimore, and she served as the 2019 president of the American Association of Women Dentists. Thank you for joining us tonight, Brittany, and spending a few minutes with us.
Thank you so much for having me. I'm delighted.
Well, Brittany, it's the 75-year anniversary of Pulp Dent and the 10-year anniversary of ACTIVA. I feel like we should be at a birthday party in Watertown, Massachusetts right now, cutting through a huge ACTIVA-shaped layer cake together, holding onto a knife. Have you ever had the chance to go to their headquarters? I mean, it's actually more like a campus now.
Well, I agree on the party part. That would be awesome. But I have been to the Pulp Dent headquarters. I was actually there about 4 years ago when I first bought my office, and it is such a cool place to visit. I mean, I always am a how is it made person. I want to meet the people. Right. I want to see the facility. To me, that's just really cool. But when you go and you visit Pulp Dent, you realize that the people there wholeheartedly believe in what they're doing, whether it's the person that's on their janitorial crew or making the products. Everyone was just so friendly and welcoming, so excited that we were there. And their whole group, they threw us the equivalent of a Boston Tea Party, which was so much fun. So we're learning about restorative materials and enjoying all these treats. And they were just so hospitable. It was awesome.
Well, there's a lot of big corporations in dentistry and some small corporations. Then there's a handful of family-owned businesses like Pulp Dent. And when you get the opportunity to go and visit with these companies, you like their products already, and then you fall in love with the people who are making them. And as a speaker, if you're going to go out and recommend this to 100 doctors, you feel so much better when you get a chance to see where it's made. And you see everything is done. Everything is made right there on that campus. Everything made in the USA right there in Massachusetts. And it makes you feel a lot better about standing up and making a strong recommendation to do it. And I'm pretty sure, I know it's after COVID, so it's hard to say, but I'm pretty sure that Pulp Dent would be happy for any dentist who wants to take a tour to come by. In fact, I would say, I don't know about you, Brittany, I would be a little suspicious of a company that said, no, we're not going to let you come by and take a tour, because obviously they're not proud of what they have to show you.
Absolutely. Yeah. Whether they're not proud or they know that there's things that might be suspect. I mean, we're using these materials in human beings. We want to know that the facility is clean, that it's organized, that things are up to code. And certainly there's areas, we couldn't go in for safety of the materials. But again, the group was really welcoming, and it made me believe that they cared about my patients and cared about me as a clinician, which really matters.
Yeah, you got to see it with your own eyes. Well, before we get to talking about how you practice now, tell me a little bit about how you were taught to do indirect restorations back in dental school. In fact, let's start with what year did you graduate?
I graduated in 2013, so I am just a few months shy of being 10 years out of school. I'm almost no longer a new dentist.
That's right. So young. And so when I was in dental school back from 1985 to 1988, it was all posterior amalgams. Obviously, the posterior composite would have been laughed off. Even if somebody was doing it, they would have really not let you do it in dental school. I'm interested, what percent of composites were you doing versus amalgams, and what was that technique like?
So I would say we were doing about 50-50, and it greatly depended on the faculty member that you were working with. There were people who preferred amalgam, that thought posterior composites were blasphemy. And then there were providers, who were really trying to push the materials and get us used to what we would be using in private practice. And I was one of the first classes to be able to have the option on my dental board exam about whether I wanted to do a posterior amalgam or composite. So now I don't even think you have to do an amalgam on the boards. So, the way we were taught is definitely different than the way I'm currently placing composites. Total etch 15 to 30 seconds, depending on the adhesive we're using, following the instructions on that. We had a variety of different ones depending on the clinic you're working in. And then we're using like a TPH packable composite, 2 millimeter increments, as you're going and you're curing and you're going under the rubber dam. And one filling takes 3 hours. Oh, dental school's great.
Yeah, that's hard to be profitable in private practice, especially if you're a participant with most major dental insurance companies on their PPO plan. That's going to be a little difficult to to make money. Well, most people consider ACTIVA to be the first bioactive material in dentistry, but the weird thing is a lot of dentists consider it to be kind of a niche product, like something that you absolutely need to have on somebody like a high caries patient or somewhere where there's going to be a lot of moisture. But the truth is that ACTIVA bioactive restorative material can absolutely be an everyday material. Give me your thoughts on that.
I would say it is my everyday material. ACTIVA bioactive restorative is the workhorse of my practice. It is what I'm using on every posterior restoration and a decent amount of my anterior restorations. When you look at a product that has the benefits of this one, the strength, the ability to prevent recurrent decay or decrease the likelihood, the potential for ion exchange, to say that you're only going to use it in your high caries patients, it's kind of favoritism, right? I want everyone to be healthy. I want everyone to have that opportunity to maintain their oral health when they're not in our practice, not just the patients that are high risk. And so for me, it's what I've switched over to using. I think that is probably the best part about being a business owner is I was finally, moving on from being an associate, able to try new products and see what I liked. And this has become my number one.
That is funny. It's like you're saying to the one patient, hey, you never floss and you eat and drink a lot of sugar and maybe brush once every 2 days. You get ACTIVA, but you patient, you just cracked an amalgam. So you're going to get some non-brand name light, packable light cured composite. It is weird to kind of like just treat people with what you believe to be is the best material, the ones who are doing the worst in terms of oral hygiene, and really kind of not reward the other people. I'd never thought of it that way before.
Yeah, and I'm about keeping it simple, right? I want my practice to run efficient. When you have 12 different materials that you're using, that can really affect your efficiency. Doc, what are we going to use for this patient? What are we going to use for this? What are we going to use for this? Like, we use ACTIVA, and if we're not using that, then I'll let you know. And it has just really streamlined our process.
Yeah, that's great. And the other thing with trying to use so many different products is dentists are notorious for not really knowing the names of their products. When somebody starts to tell you, oh, I'm having post-operative sensitivity, and you say, what bonding agent are you using? They say the one in the green bottle. And you're like, really? You're a doctor and you're not gonna even learn the name of your product? Like I had shoulder surgery a couple of years ago, and I was praying that the guy knew the names of the products that he was going to be using. But I think that's a weird thing in dentistry where they say the dark green bottle. And so anytime you can simplify it and have a standard operating procedure with one material, like you're saying with ACTIVA, it certainly streamlines things, and your office is never confused about what to do. It's going to cut down on mistakes, cut down on post-operative sensitivity. And the one thing a lot of dentists don't look at when it comes to the profitability of their office, and that is having to remake these restorations if it doesn't work 3 years later when your hygienist sees it on a bite wing X-ray at recall.
Yeah.
So the real reason ACTIVA is celebrating 10 years of clinical success is because of 3 of its components. The first is PulpDent's patented Embrace Wet Bond, which acts as the matrix. And the second is PulpDent's patented rubberized urethane material, which acts as a shock absorber. And that's also the material that powers Tough Temp, which might be the best kept secret in dentistry. We'll talk more about that later. And the third is the reactive ionomer glass filler. So I won't put you on the spot and ask you to choose your favorite component. Well, actually, do you have a favorite component out of those 3?
Oh, sure. Mine's definitely the rubberized resin component, because especially when you're dealing with patients that are bruxers, or patients come in with cracked amalgams, that they are putting wear and tear on their restorations. And I want something that I know is going to last, because no one wants to have to redo their dentistry. We see a lot of patients with high anxiety, and they want to know that it's done. Right? They don't want to have to come back in a year to do it again. That's way too stressful. So the fact that it's so durable, that's absolutely my favorite part.
So back when I was practicing at Glidewell, we were working with Tough Temp, relining biotemps with it. And then I was also using it for single unit materials if I wasn't doing like a 6-unit biotemp. And I kind of fell in love with it. And I was like, how does nobody really know about this? Everybody was using Bisacryl, just straight Bisacryl temp materials. Do you use Tough Temp for your crown and bridge? I do. PulpDent is just, they're slowly turning me into a junkie, I feel like. I started by using their restorative materials, and then I was having a lot of issues with temps, and my rep said, we have temp material. I don't know if you'd want to try it. So I did, and I found that my temps, they don't fracture, they don't come off. The ability to, patch or make an adjustment, the fact that they have a little handheld syringe, like a flowable composite that you could use to add, brilliant.
Yeah, it's been a really great material, and I was surprised that more people don't use it.
Yeah, I don't know what it is. It's a wonderful name. It's a fantastic name for one thing. So Tough Temp should be able to be remembered. But you know, it's sometimes Pulp Temp, they just do things differently than other people do. And I don't know if sometimes dentists are suspicious of it if they don't know what rubberized urethane is. But you really just got to get a sample in their hands and let them try it out. And the analogy I always use is if you're on an airplane and you watch the wing in turbulence and it's bouncing, you know, you'd rather have that happen than have it fractured. And that's exactly what I picture Tough Temp doing under load, you know, in a Brux or a grinder like that is giving and not breaking. And you want something like that, whether it's a direct restorative material or whether it's something like a temporary crown or especially a temporary bridge. Well, let me ask you to pick another favorite then out of the ACTIVA family of materials. So the bioactive restorative material, the bioactive base and liner, or the bioactive cement. Which one of these three would you have the hardest time practicing without? I already know what the answer is because you kind of already said it.
I definitely couldn't work without the restorative. I mean, it's changed the way I practice. It's changed the way, or I would say it's allowed me to change the way I communicate with my patients. It's really let me focus on patient education, and through kind of, I was a chemistry major in college, so through kind of nerding out over the material with my patients, they're like, oh, that does all that, that's going in my mouth. And it just opens up this conversation and this level of trust that, yeah, if you told me tomorrow that I had to stop using it, I would be so miserable. Yeah. Or that there was a shortage, I'd just start hoarding it. I would just be stocking it in all the nooks and crannies of my office.
Like toilet paper during COVID, you would be hoarding
100%.
Bioactive restorative material.
Yep. Wouldn't think twice about it.
Buying it through back channels on eBay, guys in unmarked vans coming by your office.
I know some people at Pulp Dent.
Exactly. Yeah, you do. You've been to the headquarters. You probably had a copy of the key to the front door made while you were there, just in case that ever happens. I'm guessing, I don't know, but do you feel the same way about the bioactive cements as well? I mean, if you love this ionic exchange that's going on at the margins of your indirect restorative materials, I'm guessing you love that ionic exchange happening, because I can tell you, even in the best case scenario for an almost perfect crown, that margin is still open 50 microns in the best case scenario. It's not closed.
Yeah, exactly. And for that reason, I feel like you're silly not to use it. If this is going to help to absorb fluoride and prevent recurrent decay, it sort of covers all of your bases in that sense. And I find that it's really decreased sensitivity after inserting crowns. You know, sometimes patients are fine in their temp and you put their crown in, they've got some lingering cold sensitivity, or the first couple of days they're uncomfortable. And in using the bioactive cement and the, you know, my core buildup is usually the ACTIVA restorative, that post-op sensitivity has been decreased tremendously.
Don't you think that as a GP, one of the biggest nightmares, one of the biggest things that you'll lose stomach lining over and start to question your ability to do quality dentistry is post-operative sensitivity, where you know that you, as far as you knew, did everything right on that tooth, and now it still hurts? I mean, those are the days where I want to work at Starbucks and just be a barista.
Well, and especially as a newer graduate, you're like, is it something I'm doing? You know, you're kind of going over and talking to your colleagues, or maybe the dentist you're working for, you know, am I doing something wrong? And, you know, a lot of people say, no, that just kind of happens with composite. And I thought, well, why are we doing so many composites if people have so much sensitivity afterwards? It just didn't make sense to me. And that was that was probably the first thing I noticed in using this material that was different, is I was having so fewer reports or many fewer reports of post-op sensitivity.
That's amazing. Well, the ACTIVA family of materials, as we mentioned, releases and recharges calcium, phosphate, and fluoride, and it promotes apatite formation. It reduces micro leakage at the margin, whether it's a class 2, which is the big cause of secondary decay and restoration failure. I mean, how would you not want to use that as a restorative material and a crown and bridge cement? What would be the thinking behind not doing it?
I don't have an answer, you know, and I would say that even my team is on board. You know, we're always talking about ways to increase our production in hygiene or otherwise. And so my hygienists they say, well, you know, when you do this fluoride treatment, this helps to recharge the fillings that are in your mouth that Dr. Bergeron placed. They're going to absorb this fluoride and help to prevent you from getting a cavity around the filling. And patients like, yes, please, I'll take that. you know?
I'm writing that down. Thank you, Brittany. That's good.
Yeah, yeah. And that, you know, that makes my team happy because then their production's up. It makes me happy. We all know fluoride has great benefits for patients. So, you know, we talk about that is it's comprehensive care, right? Not just, I'm not the only one having a conversation about the restorative materials. It's my team as well.
Yeah. Well, we were at a staff meeting the other day, and I said, why aren't we offering fluoride to everybody? I just wondered, why are we only offering it to people whose insurance pays for it? I just was wondering.
Why are you only using good materials in patients with high caries rates? Let's treat
exactly.
everyone well.
And one of my assistants said, well, what does it even really do? And you know, one of the things is recharge bioactive materials like this and give them longer life. So it's like an insurance policy on somebody. So we don't only have 6 or 7 posterior composites. You know, it'll have the ability, if they're bioactive materials, to be able to recharge it and give them longer life. So it's like them taking on a longer insurance policy on the dentistry that they've already paid for. And so it seems like most of the world today is light curing, you know, posterior composites in 2 millimeter increments. Does the fact that ACTIVA restorative material is dual cure, is that a big part of what makes it attractive to you?
It's a huge part of what makes it attractive to me. I mean, think about the time, and that's assuming, think about the curing light you're using. Are you using, you know, a 3-second cure, a 20-second cure, and then you're doing a deep posterior restoration? It's minutes that it's taking you to do that. You know, that the patient's open wide, that you're trying to, you know, keep everything dry and isolated, that we see a lot of patients with really high anxiety. And so to just be open that long, a patient with TMJ issues, that, you know, you can instead give them an opportunity to kind of close down a little bit, depending on the patient. You know, we'll sort of quick kind of tack cure the top layer and then let the restorative material do the rest. And you're doing a core buildup, something like that, the time that it saves you is awesome. And then we know, you know, that it's bonding to the tooth better.
Right. Well, you've been nice enough to share some slides for us. So as the production team pulls up those slides, I want to ask you, do you love the color pink?
How could you tell?
What is that behind you? I can't tell what it is.
So this is a tooth. I'm not sure how well you can see it.
Oh, yeah. Okay.
Patient drew this on the wall in my office. So yes, I always said that if dentistry didn't work out, I was going to be Barbie. And as a result, I've been gifted many dentist Barbies by my patients. So they sit on a shelf above my desk, which is really fun.
Oh, that is so smart. Oh, that
and
is so great.
And we do have male patients. I get that question a lot. We still have men that come and see us. It's only this room that's pink, but you know, if I have to be in here, I'm going to enjoy it.
Why do you allow male patients, may I ask?
Why not?
No, I don't know. Because it seems like they're the ones who don't floss. They've never used bridge threaders. They're the ones who wear their clear aligners. I don't know.
We try not to have that implicit bias around here. We don't stereotype. Everybody gets a clean slate when they walk through the door.
Okay, well, I guess as a male, I can say that about males and not get canceled, hopefully. Okay, so walk me through your slides.
Okay, so I just put together a few cases just to kind of show you examples of where I'm using this in my practice in every day. So this was a patient, she's a bruxer, non-compliant with her night guard, and she has a number of full coverage restorations on her posterior teeth, and she's having biting sensitivity when she's chewing on this tooth. Her insurance company says, well, we're not going to pay for a crown because there's no piece of the tooth missing. So the patient says, well, what am I supposed to do? I'm having a hard time eating on that side. It's sensitive. This distal piece here is moving. You know, there's no option because my insurance company isn't going to pay. So as a practice that deals with insurance, you know, we take a lot of the PPO insurances. We sometimes have to be creative in our treatment planning if a patient is not willing to have an out-of-pocket expense. So this is a situation that we did just that. And in choosing a material that's now going to be responsible for supporting this tooth, I thought that ACTIVA was a great material because of its strength. So we cleaned up the major fractures, we left some of the craze lines here, and then we went ahead and restored this tooth. And the patient has now had this restoration in place for probably a year and a half. Biting
Mm-hmm.
sensitivity is gone, no more discomfort. She's now being compliant with her occlusal guard, which is obviously great. But she hasn't had to have the tooth crowned, and she's feeling awesome and also excited to save on that expense. So just, you know, a simple example on when you're trying to give your patients options, unfortunately, what is ideal dentistry doesn't always work for a patient, whether it be for financial reasons or other reasons. So being able to give them an alternative that's going to be long lasting is important. And this was a situation that we were able to do that.
And I'd say aesthetically, you outperformed the crown distal to it as well.
Thank you. Thank you. You know, you look at this and you can always be self-critical, but yeah, you know, she was really pleased with it. And at the end of the day, that's what really matters.
Yeah, and I mean, maybe she does break that lingual portion off at some point, does need a full coverage crown, but you know, I can see your conservatism here, and obviously there was insurance concerns and money concerns, but I
Yeah.
think that's a conservative way to be able to do it, because you do see teeth like this in people who are 80 years old and they still look just like they did, and there's something to be said for it. Now, honestly, you know, 40 years ago, my dad would have done that same thing with gold. But again,
Yeah.
there's a cost factor involved there, but dental insurance didn't exist. So the dentist said, do this, and the patient usually said, okay. So I think that's wonderful that you're being conservative and giving options. And then when you look at what you would have paid in terms of a lab fee and the prep time
Mhm.
and the seat time, you know, when you look at the cost of the Activa, it's funny that Activa restorative material does all these wonderful things that most light cured composites can't do. And yet, if you compare it to the typical light cured composites, it's 10 to 20% cheaper. You know, you expect it to
Yes.
be 30 to 40% more expensive. So I don't know how much time this took you. I mean, in a sense, this could have been a more profitable procedure than you doing an indirect restoration like a crown.
Sure. I mean, you know, in this case, we're working on a lower premolar. We were able to give her a mental block, clean it up, restoration, 20 minutes, 30 minutes, the patient's, you know, out the door. So when you're talking about that, this is a huge success. You know, you mentioned about the cost of Activa, and I thought for sure that this was going to be a really expensive material. And I thought, oh, this is going to be one of those materials that one day I will get to use. You know, I bought a startup practice and we kind of had to ramp up. We were finally up to 4 days a week. And I thought, I'm never going to be able to afford this. And when I looked at it, I thought, oh, well, maybe this is wrong. You know, there's a promotion. I said, oh, it's just because it's a promotion that it's inexpensive. But that's really not the case. And then I was convinced that the tips, because the way you dispense the material, oh, you lose too much material in the tips. Well, you can go on YouTube and see, you know, they weigh the tips and the amount lost is minimal. And I've never had to buy new tips, which is always my complaint when I use other products that are in that auto mix range, is they give you 10 tips. You're like, what am I going to do with 10 tips? I have all this material. I've never had to buy more tips. So I really feel like the packaging is thought out.
That is maddening. And speaking of the packaging, the Activia Spencer, I think is really well thought out as well. Oh, I said it. We had a joke before we started that because I used to have an Activia joke in my lecture right after I talked about Activa. I would talk about the yogurt, and I told Brittany we should have, instead of a swear jar, if I make a mistake and say Activia instead of Activa, that I would give $10 each time I said it to Pulp Dent's charity of choice. So I'm going to mark that down as a 1 for me, a 0 for you. But the Activa Spencer, you have to just love how this was designed. You know, the way the cartridge slides in and everything. It's like 4 R&D people were locked in a room for 20 hours and told, don't come out until you have something that makes total sense. And it's sexy. It's great. I just love things that are well designed and feel good in your hand. And running out of tips is one of those things where it's not the end of the world, but it's super annoying to have to go and do that now. I find that now with our intraoral scanner, you know, ordering more and more tips with it. I'm kind of like, this is ridiculous. I know in other countries they aren't redoing this, and I just paid, you know, $60,000 for this. Do I really have to pay $500 for another bag of tips? So that kind of thing can be maddening to a dentist. That's a great case. What else you got?
Let's see. So this is a patient, very high caries risk. She has ended up with most of her teeth being restored, both posterior and anterior, rampant decay, not really on any specific fluoride protocol prior to coming into our office. And she's a bruxer. She has a lot of wear on her dentition. Her occlusion is just really malaligned. She's been through ortho. She doesn't want to try again. So we're kind of stuck working with what we have. So, you know, when you're looking, this is number 30, when you're looking at a tooth that already has so much wear, she doesn't have a lot of clinical crown height here if we're talking about doing a full coverage restoration. So in working within the patient's means in an attempt to just kind of go through and do caries control, which in a situation like this almost makes you feel like you're in dental school again. Caries control was always what they were preaching before you started restoring. But, you know, there are situations that you really have to do that in practice to be able to put out fires and prevent patients from needing more extensive dental treatment. So this is a situation working on this patient. You can see she had a composite here. She's got a hole, whether it be in her tooth or the composite, and a lot of recurrent decay that's happening underneath. So this is a picture after we've kind of opened things up and cleaned it up. A little bit of stain left here on the mesial wall, but otherwise we were able to really, you know, get things in a shape to be restored. And then here's our final restoration. So this is a tooth that doesn't have a lot of anatomy in it. So the restoration ends up looking, you know, kind of rounded or smoothed out in comparison, especially to her second molar behind it. But, you know, she doesn't have any postoperative sensitivity. I was amazed. This is one of those cases that you think, base liner, well, we're using this bioactive material, it's going to help to soothe things. And we just went for it. And she still feels great 2 years later. And the restoration hasn't changed at all. I said, I want to take an updated photo, and it looks almost exactly like this photo. So I just included the post-op photo because it's really not much different. And so
it's got to feel great. I mean, you've got somebody like this with all these caries and you're scooping it out, going deeper and deeper. I start getting nervous about incrementally placing light cured composite and hoping I'm curing it enough, but not too much so that, you know, with a high powered lamp, so I'm overheating the pulp or something. It's just, this seems to me just screams out for a dual cure solution like this, so that you're, you know, not getting shrinkage and contraction stresses, and you're making sure you don't have uncured composite at the base of this against this. So this feels like one of those areas where you would really appreciate its dual cure nature.
Absolutely. And then, you know, this is a patient that now she's on a fluoride protocol at home. She's using ClinPro in place of her regular toothpaste. And so she's just constantly hitting these fillings with more fluoride and hasn't had decay since we finished her restorations, which, you know, for someone who comes in needing 20 to 24 restorations to go a year with having no decay, that's awesome.
By the way, every human fossil they found has anatomy like the first molar instead of the second molar. It seems like our ancestors, from eating stuff with mortar and pestle and eating stuff off trees, flattened off their anatomy and had way less TMJ issues that we do. I kind of think even at the lab, we should be making crowns with less anatomy rather than more anatomy. So I don't know. I like doing those ones like you do with no anatomy. I think that's great.
Yeah, you kind of look at this tooth and you think, do these two teeth belong in the same mouth? Like what happened here? But, you know.
Yeah, one's from the Paleolithic era and then one's from like modern pasta eating human beings. It's like one of these is from the wrong 10,000 year era.
Exactly.
All right.
Exactly.
Let's see what else you got.
Oh, this was a really interesting.
Yeah. There you go.
Yeah,
this is why everybody has a box of Activia in their office, right?
Talk about being in there, you know, this is one of those situations that your hygienist comes to you and they kind of peek around the corner and they say, Doc, and you're like, what? Doc, don't get mad. And you're like, don't get mad, what just happened? Well, what happened is on scaling, their former composite was failing and popped right out. So now we're in a situation that we want to fix this same day for the patient, and you're looking at this tissue like, oh man, this is going to be fun, right? Trying to isolate this area, trying to cure somewhat into the furcation, which is exactly, you know, where we are here. This patient has moderately controlled periodontal disease. You know, it goes through good periods and through bad. So this was a situation that we actually went in with our laser to clean up some of this tissue just so that I could have direct access before we prepared this surface. And in a situation like this, where you're on a very tight schedule to keep things isolated and dry, having a dual cure material is awesome, and a material that's somewhat hydrophilic, that's not going to totally fail on you if there's a little bit of moisture. So this was the final restoration, and again, you know, it's hanging on, it's still in there. I said to the patient, this is a fix for now. You know, long term, you're probably going to lose this tooth because of the furcal involvement, the bone loss, and he's able to keep it clean. What I've found about this material is that when I'm using the ACTIVA restorative at the gum line, it appears, and whether this is proven in research or not, but it appears in my office at least, that these restorations are holding on to less plaque. So patients really are able to keep them cleaner. And I've had a couple, you know, colleagues when I'm giving lectures and talking about this who have said that they've noticed the same thing in their practice. So when you're talking about this posterior class 5 that's up against a tilted third molar, you know, already an area that's difficult to clean, this is really a win as far as I'm concerned.
Right. Yeah, there is a study. I think, I don't know if there's more than one, but I know there is a study showing that ACTIVA, that the biofilm reduces, has less surface attachment to it than it does to other restorative materials. Polished zirconia is quite the same way. You know, it's got less biofilm accumulation like ACTIVA as well, which is perfect in a spot exactly like that. And it's funny, again, to your point of why are we using our best materials on our worst patients, but I think this is why everybody has a material like ACTIVA in their practice for these, you know, crazy kind of fillings they have to do. But it's like, if it's going to work for the hardest of situations, why wouldn't it work for everyday situations? And the dentist answer would probably be because it's more expensive. And you're like, how do you know it's more expensive? And they said, because it works in these really tough situations. And it's like, well, have you ever looked at the price? Because it turns out it's less expensive. And so maybe that's where it got the reputation of being so good that it must be so expensive, to your point about finally looking it up and saying, oh my gosh, it's actually not as expensive.
Yeah. Well, and what's your time worth? Do you want to continue to redo your restorations? Do you want to be light curing in all of these small little increments? You know, if this takes 2 to 3 minutes to set, could you do a hygiene check in that time? Could you take a call or answer a question from another staff member? You know, it increases your efficiency, and that, to me, my time is important and is incredibly valuable. So yeah, I think you have to look at finances in different ways.
These are all great examples. Do you have another one?
I do. This is last one here. So, you know, just distal caries up and against, you know, an amalgam. And so we were able to clean this up, and a composite in the area. You can't even tell it's there. So to say the patient's pleased, you know, patient knows that they're pleased because you were able to work quickly and they didn't have any pain. I was pleased with how it looks. You know, I'm always excited to show patients the picture. What do you think about this filling? They kind of look at me like, yeah, doc, it's a tooth. Okay, you're crazy. But, you know, so just a few examples that in the most conservative situation, you can use this. And then for a tooth that you're working down on the root surface, sort of in the trenches, so to speak, this works. And that's why it's become the workhorse of our practice that we're using on every patient.
Oh, that's fantastic. Yeah. And so that's great. I like the idea of you turned it into the workhorse and how you make it so easy for your staff to know we're using ACTIVA unless I tell you that for some reason we're using something else. What are some of those cases where you find yourself, okay, maybe I'm not going to use ACTIVA for this case?
So I would say if I'm doing something in the ACTIVA comes in limited colors. So you're looking at the A123, and then there's an opaque white. So if I need a color match that's outside of that wheelhouse, I'm going to be using a different material. So depending on the patient tooth structure, I might use an omnichroma. But if I can use something that still has these properties of the ion, you know, release and recharge, like the ACTIVA Presto, I use a lot of that in my office. That comes in A1 through 4 and A6, I think. Most people, you can kind of put them within that range, and sometimes even layering that over a different composite gives you a really nice aesthetic result. Because of the Krista technology, it just polishes so well that it gives that like glossy shine like your enamel would have, or like a porcelain restoration would have. I've even used it to do some crown repairs.
Yeah, so the R&D team has now introduced the Krista MCP technology, which is currently available in the ACTIVA Presto and the Limelight Enhanced Cavity liner. It was funny when I was talking to Pulp Dent a little bit before, they said, oh, she mixes the ACTIVA Presto with the ACTIVA restorative material. And I thought you were like mixing it together like paste, but you're actually layering it, right? And you're not, I was like, wow, there's some crazy chemistry going on here.
The mad
I was,
scientist.
I was proud of you for being the mad scientist. So I think I know the answer to this, and we have some viewer questions we're going to get to in a minute, but I have a couple more I wanted to ask you. Do you feel that using bioactive materials has allowed you to be more conservative in your practice that you would have been had you been using, say, traditional materials?
Oh, sure, absolutely. And I worked with the Indian Health Service for a period of time when I was in dental school, and I worked with a dentist there who used a lot of Fuji. That she would say, well, this patient can't have a root canal, or they can't stay, they can't do the crown, so we're going to put this material in. And she was doing her own case studies, kind of tracking how the decay was being slowly kind of turned into healthy tooth structure by using these materials. So that really got me thinking about, well, why don't we do this in a young patient, in really any patient population? I'm not saying leave tons of decay, of course, but there are situations that you think, oh, I'm pretty close to the pulp. Let's kind of see how we do. And even if it gives the patients another 6 months to a year, they're usually appreciative, and that did them a service. So knowing that this material is strong enough to support the functions of everyday habits in bruxers and otherwise, it's really easy to be conservative and to be able to place a composite restoration versus doing something that's lab fabricated.
And you've kind of answered my next question a little bit before by telling me how you talk to patients, but I'm interested how you discuss bioactive products with your patients. Is it something that just comes up when you're doing a restoration, or is it during your new patient exam that you kind of bring these up as part of your philosophy of what you're doing to gain their trust? I know you've built this practice up relatively quickly, and so patients are obviously liking whatever you're telling them, and they have this trust with you. I'm wondering, is it just at the restoration appointment that you mentioned, or you actually mention it like during the new patient exam, or how do you kind of couch this within your talk of dental materials?
We are big talkers. I'm really big in education. I want patients to feel like they hold the power, right? And education makes people feel that way when they understand what's happening. So I would say when I'm talking about it in hygiene, I kind of review, say, a common question I get asked, or is it going to be a metal filling or a tooth colored filling? It's a tooth colored filling. We use an upgraded material because we want you to be healthy. You're doing your part at home, you're brushing, you're flossing, you're using your fluoride toothpaste. We want to make sure we're doing everything on our end to keep you healthy. And then I talk to them about the ion recharge and release. And then when the patient's in my chair, we always review again. This is what we're doing today. I know we talked about it, so that I can go through if they have any questions. And that's when I'm going to bring up the decreased potential for post-op sensitivity. That's when I'm going to say, because of the way this material works, we know we're getting a really good seal to your tooth. And the most common place to get a cavity is where the filling meets a tooth, because there's a difference in the texture. And then this material is going to help to prevent that and fight that bacteria. So as long as you keep up your end of the bargain, we're doing our part. Because I always say, contrary to popular belief, we do want you to be healthy. We're not hoping that you have cavities every time you come in. And the look of shock on people's faces, they're really stunned to think that I would want to be keeping them healthy. I don't think a lot of patients perceive dental care as us trying to keep them healthy.
Right.
So talking about this material has really been an opportunity to do that. And then, like I talked about with the fluoride, keep using your toothpaste at home. You're just one layer on top of another, doing good things for these restorations. And it makes people feel like they can make a change, a positive change for their health.
Yeah, I tell people that all the time. We don't want you to have cavities. I just want you to have crooked teeth so I can do Invisalign. And I want you to have obstructive sleep apnea so I can make you an appliance. That's all I want you to have. This decay stuff is ridiculous. Stop having it. I don't like treating it. I'd rather do these other things.
I love being a restorative dentist. I could drill and fill all day. Love it. Yeah.
My last question for you, and you kind of already answered it, was I was going to ask you how bioactive materials have increased your practice revenue. You said as a startup practice, you kept one eye fixed firmly on cost and thought maybe one day we can avoid this, or this. Now that the bioactive materials like ACTIVA have become your go-to material, how have you seen that it's helped your bottom line?
I would say overall efficiency. The fact that you can work more efficiently with the material being dual cure. The material can set, we usually use like a bite prop for a patient, so the material sets and I can be doing something else, getting ready for the next part of the procedure. The fact that it's dual cure, if you're doing a core buildup, you can cure the top layer and start your crown prep right away. You're not waiting or doing smaller increments. Again, we see a lot of patients with dental anxiety or that have some sort of TMJ pain from being bruxers, whether it be stress, medication, airway induced, and the opportunity to just kind of take a break and close your mouth while the filling sets. It's huge for
that's nice. Yeah, it is. And we'll have, you know, things in people's mouths sometimes, like an Optigate, and you kind of forget sometimes if we're doing some IPR, yes, and then we're going to do 50 minutes of putting attachments on the upper and lower teeth. It's nice to give them a break and just let them close. It just stops like the panic attacks from starting or whatever.
Like
so it's not just
you know, they can't swallow. I can't breathe. I can't swallow. It's like, you can. You're just open. It's kind of hard to swallow with your mouth open, you know. But that really helps to minimize anxiety. The less stuff that you can have, you know, close to a patient, whether it be their face or their neck, all of that matters. And then people talk. Your dentist is using material that keeps your teeth healthy. It's like, well, and we've had new patients call and say, well, you know, you saw my boyfriend or my friend and they said you're using a special material that makes it less likely for them to get cavities. They're listening to me? That's great. You know, and just slowly, by people feeling cared for, feeling that I'm trying to do everything I can on my end to keep them healthy, most of our referrals are patient-based, which is the best kind of referral.
That is the best way to do it. So it sounds like you're saying, don't just look at your sundries bill and see if it's going down to find out how something like ACTIVA is saving you money. Maybe have your assistant time you know, and see what your class 2 composites, see how long they take compared to how long they used to take, and look at both of those things and combine together. So the efficiency and the fact that it is a slightly cheaper material are both going to team up to help you, especially if you're taking like a PPO from one of the large dental insurance companies. I mean, you're just not getting enough money to spend that kind of time doing these things.
Yeah. And you know, the delivery system, you hold up the gun before. I sometimes have a hard time when I'm using a traditional composite gun, you know, when it gets to the end and you're trying to squeeze it out, that hurts my hand. So using that gun, I find it's more ergonomic. But for anybody who uses temp bond or similar products, all of those cartridges are the same size. So, you know, my assistant used to have to like push the temp bond down on the top of the counter to get it started. Now we just put it in the gun. So anything that fits that little mini mix tube, we use. So we've got ACTIVA guns everywhere, maybe different products in them, but it's helped my staff as well. That they're like, oh, I have to use that. It makes my hand hurt. So
yeah, the mini mix will take any 1-to-1 cartridges, and it does feel fantastic in the hand. All right, let's move on to some of our viewer/listener questions. Question number 1 for you, Brittany. Why not use ACTIVA as a base and then cover it with a composite that matches color better?
I mean, you could do that, but I would say the main reason that I'm not doing that is because of the bond that's happening between the ACTIVA and the tooth interface. I want to know that the restoration is protecting against micro leakage from bacteria, and that's what ACTIVA does. It just bonds better. You know, I use a lot of A1 and A2. There are certainly different colors. If I'm concerned about the aesthetics of it, I will layer ACTIVA Presto, which is still bioactive, over the ACTIVA BioACTIVE restorative. And I do that a decent amount now that I'm, you know, using the Presto more and more, because I know that it at least still has those properties of the ion exchange and that increased bond strength. I feel like leakage at the margin of a composite due to the heat of cure is just, it's so frustrating, and it's something that happens to everybody. So, you know, also knowing that it's dual cure, if you don't want to light cure it, you don't have to, in which case the potential for shrinkage of the material is so much lower. So that's really why.
So yeah, so the point is, you're not just worried about leakage at the base and the sides of the proximal box. You want to have that same great seal along the occlusal outline of it as well, so we don't get secondary decay starting there as well.
Exactly.
Okay. Question number 2, how well does ACTIVA hold up long-term as a final restoration?
So I've been using it for 4 years. So that's as long as I can comment on. I've owned my office for 4 years, and I have redone very few fillings. I don't know an exact statistic, but I started using it exclusively in 2019. And even through, you know, I feel like the pandemic was the biggest test of materials, right? You had patients who were, I have patients who still haven't been in since COVID. And the one thing that I can comment and say is that they don't have recurrent decay around their ACTIVA fillings. Around other restorations, we've certainly seen a lot of recurrent decay, whether that be from people being dehydrated, mask wearing, junk food, you know, not coming in for their routine care. But it's definitely, as far as I'm concerned, a material that lasts long term. Like I said, I'm only been in my own office for 4 years, but been pretty impressed with what I've seen so far.
You know, PulpDent's done a really good job with their, we said it's their 75th anniversary, and their catalog this year, their 75th anniversary catalog is beautiful. And it's got a lot of photographic befores and afters, and there's a lot of pictures of 10-year ACTIVA cases in there. And so, yeah, I don't have any as well. Most dentists don't necessarily take pictures of it, of, you know, every restoration they do, unless it's, you know, more so with veneers and other indirect restorations like that. But PulpDent in that catalog, if you call and ask them for it or go on their website, you probably just download a PDF. Yeah. And yeah, there's some fantastic views of all the materials holding up under duress. And they even, and when they show and explain how the rubberized urethane materials allow it to function for a long period of time, you begin to understand why it can be functional and strong for that long of a time period. But it is different, but that's the good news about it. Question number 3 from Omaha, Nebraska. Thank you for telling us where you're from. Which matrix system do you use with ACTIVA? I have used it practically since it appeared on the market, but I do not feel comfortable doing MODs with it on molars and premolars. I do use it for OB and OL restorations, and I do like the product very much. Thank you. So it sounds like the concern here is with the bigger restorations, kind of like that MOD that you did on, what was that, number 20 that you did on that one patient who couldn't afford the crown?
Yeah, so that's a great question. And that's something that I talk a lot about when I talk about PulpDent products. Because this material is flowable, matrix selection is key. You're not going to be able to pack and condense this material down. So I will choose a sectional matrix for this. I personally really like the Ultradent, the Triodent system. That's what I'm using the majority of the time, making sure that I've got good adaptation of the band. And then I'm really wedging those teeth, you know, and then the ring helps to put extra pressure. But if you're doing that, even though this is a flowable material, it's usually pretty foolproof. Every now and then I'll be unhappy with the contact and have to go back and redo it. Certainly if you're doing, you know, an MOD on number 2, you're going to have to use a conventional matrix band. And I would say when it comes to that point, you know, using a hoe band or something that's the equivalent. Again, I really like the Ultradent, the Omni Matrix. They're disposable matrix bands. You can angle them a little bit easier. And then just making sure that you're really burnishing and wedging. But my preference for this is definitely to use the sectional matrix.
Okay.
That's a great question.
And so because it's a flowable, it all just comes down to the matrix and how much separation you can get that wedge in there and get everything all sealed up before you go with the flowable.
Exactly.
All right. Next question. What is the length of time? What is the length of time for curing ACTIVA if it's not subjected to a curing light? So I guess they're saying if you didn't use a curing light and just let it go through its dual cure or auto cure mode, how long would you wait before, I guess you would say, finish the occlusal surface?
Yeah, so it's about, I want to say it's about 2.5 minutes. Okay. Now I feel like I should look that up, but it's around that time frame. Okay. I don't know. Now I'm feeling like maybe I shouldn't be quoting that specific. You have the ACTIVA. Does it say on the cartridge? Wait a minute.
Let's see. I don't know that it says on the cartridges.
No, it's on the
itself. But I know that most of the people.
Minutes, 2.5 to 3 minutes, says Dr. Google.
Okay, I know that most of the people who use dual cure materials like that are basically waiting 90 seconds, you know, to get everything against the to surface, you know, to use the dual cure mechanism, and then light curing it towards the end just to get that final cure. So I'm not sure if, and some materials don't even recommend just letting it completely cure on its own. So I don't know. This is one of those, definitely read PulpDent's R&D team. I'm sure it's put a lot of work and a lot of hours into this. And so I'm going to take your 2.5 to 3 minutes, Brittany, but I don't happen to know their opinion on not curing it at all and just letting it dual cure. So that's definitely something
I
You'd
wear a
want to
loop
check on
light,
the
so
material
to
names.
some extent, if I'm looking down at the prep, there is some level of light on it, you know, with the shield or otherwise. But I'm a big fan of reading the package insert. That may be the unpopular opinion, but I do, if I'm using a new material, I will read the directions to make sure that I'm doing it right. You know, I'm always curious when people say materials have failed, if they're failing because they were actually failing, or because maybe there was something that was missed in a step being taken, you know,
Right.
wait time, whatever that might be. So when all else fails, read the instructions.
And it's kind of like how dentists like to mix and match. They're like, okay, we're going to use the etchant gel from this company, the bonding agent from this company, and we're going to use the adhesive from this company because that's what we think is going to be best. And it's kind of like, hey, those chemists maybe have never talked to each other about how these three things will work in combination. I don't think they're having any combo crossovers about, hey, let's see how we can use these together. And maybe that connects to our last question of the night. It says, I don't know what he or she is quoting here, but it says studies have shown that ACTIVA has no self-adhesive properties. Do you use an adhesive system with ACTIVA?
So it depends on the situation. I would say that if I'm doing, let's say after a root canal and I'm doing a core buildup down in the base, if I'm usually not using an adhesive in that situation. There are times that I do not. Out of habit, I do use a bonding agent the majority of the time, but there are certainly situations that I have not. And I would say that the success has been no different as far as post-op sensitivity, as far as adhesion. There has been no difference. And, you know, PulpDent's done a lot of studies on if you're using an adhesive or not, you know, are you still going to be getting that ion exchange into the tubules and the apatite formation? And you are. Because of course we know no bond is perfectly sealed, right? There's always some level of leakage that's happening.
Well, Brittany, thank you so much for spending this hour with us tonight. And thank you for pointing out that I now owe PulpDent $10 for saying ACTIVA. What I'd like to do is you and I
Does that count? Can it be 20?
Can you? No, that one doesn't count. That was intentional. We could meet at their headquarters at the campus and present them with an oversized $10 check and maybe get the updated version of the tour that you took 4 years ago.
I like it. That would be awesome. That would be awesome. You arrange it and I'll be there.
All right, Christy, make it happen. Thank you. All right, thanks again for your time with us tonight, Brittany. Appreciate it.
Thanks so much for having me. Have a great night.
Well, that'll end tonight's program. My thanks to Dr. Bergeron, to the commercial supporter of this program, PulpDent. So on behalf of myself, Brittany, and all of us here at Inside Dentistry, I want to thank you for your time and your continued commitment to quality dentistry. And one programming note, we'll be doing another one-on-one with Dr. DiTolla February 8th at 7 p.m. Eastern. Be there.